initiative to incorporate many other.
Sorry, Khatuna, did you assign me as an interpreter? I did not receive any buttons yet.
Yonash is now trying to assign you because, yeah.
Janusz, did you manage to assign me as an interpreter? You are muted, I don't hear you.
Give me please 1 second.
Okay,
Yeah.
okay.
There seems to be, yes, you are added, Nina.
Oh, thank you, thank you. I'm added.
Bodish gixdით შეფერხებისთვის თარჯიმნის მე მგონი სისტემა ხელს გვიშლის, იმიტომ რომ დილითაც გქონდა შეფერხებები და მე მგონი ახლა უკვე გასწორდა ხო ნინო? Yeah. Okay. If there is a problem again, shout or put it in the chat window. All right. If we are set to go, then I'm very happy to say that within the framework of this big initiative, we were happy to partner with UNFPA, our colleagues in UNFPA, and
It looks that Khatuna is lost. So I suggest to start with the first speaker, with Dr. Anna Hanchar. Anna, please, if you can share your screen and start your presentation.
Hi, everyone. Apologies, I have a bit of a child situation here, and I do apologize for that. It should be resolved very soon, hopefully. In the meantime,
I prefer that we swap the presentations.
I was just about to suggest, can we swap? Because Haneni is just coming in through the door, and then I'll just jump in after your presentation. I'm so sorry about that.
No worries.
Thank you.
I continue with my presentation and after.
Thank you.
Natalia.
Yes.
It seems that we have multiple issues today, and we lost Khatuna somewhere, but I'm sure she'll be with us shortly. My name is Karla Koutková, and I'm the moderator of the roundtable discussion. So let's just proceed with our second presenter, Natalia Zakharishvili of UNFPA. Then we go on with Anna, and then we discuss with Dustin the research of this endeavor. Thank you very much, Natalia.
Thank you. Good afternoon, dear colleagues. I will join my team members and my colleagues to acknowledge how on time and important it is to hold this important meeting, Research for Policy recommendations. And today I have an opportunity to talk about our UNFPA UNDP joint initiative that we implemented during the 2020 about low uptake of HIV testing in Georgia and how we applied behavioral research, and a little bit about the project itself and findings. So a little bit about background information that the country's HIV prevalence in terms of the epidemics, in terms of the HIV prevalence in general population. I'm sorry, something is, excuse me, some tables are jumping out from the survey. So in terms of the epidemical situation, HIV prevalence in Georgia in general population is very low at the country level, but still country faces significant risk of expanding epidemic because of the high risk practices, because of HIV prevalence growing among the key population, because of significant risk of sexual transmission. So this bridging population, and epidemic is still concentrating among the key population, MSM, people living with HIV, ID users, and sex worker. So the main route of the transmission is sexual contacts, followed by the injected drug use. In terms of the UNAIDS 1990, the fast track targets, Georgia is very well positioned for the last two targets. But in terms of the first 90 target, which is very important for us, HIV prevention, we're a little bit behind of it. So it means that in 2000, it means that the only 70% or only a third of the population know about their status. HIV prevalence in MSM has increased dramatically over the last couple of years, and you see the figures that it's from 37 to 20% in 2015. This is the latest information. What about the challenges and why we need to stress on the challenges at the country level? So we have any challenges starting from the quality of care. Let's start with the late diagnosis. That remains a significant challenge. Despite the many positive developments that is happening at the country level in HIV control, we still have the main challenges what we need to focus on. And this is a late diagnosis. This is that only 51% to 55% approximately knows only diagnosed persons were presented to care late. Individuals are not aware of their HIV status, and they continue still in high-risk behaviors and unknowingly transmit the virus, which is a basis to fuel the growth of the epidemic. And late diagnosis is the leading cause of the deaths in Georgia. Requires the additional resources to treat advanced diseases. So in general, testing uptake in Georgia is low in general population, in key population, as well as young people, including young people, young key population. So here comes the issue of the stigma and discrimination. Why people are reluctant to seek HIV testing, and we'll have an opportunity to talk about the stigma and discrimination issues a little bit later. So again, the access to healthcare services isn't a barrier because of the HIV positive status, and this is also related to the stigma and discrimination. We can talk about the quality of care, why is an important challenge, and how is again related to the low testing uptake. What is the challenge about the comprehensive and systematic way of continuing medical education, and how is related with the quality of services? About the stigma and discrimination, when we're talking from the perspective of the general population, of the adolescent young people, and from the perspective of the healthcare providers. So this was a main topic what we are looking for in the research. So about the young people, I want to stress a little bit more about the youth. Why? Because they represent the high portion among the key population itself, and they are particularly vulnerable to HIV due to the lack of access to the services, lack of access to the sexual reproductive health services, lack of access to information, stigma and discrimination. And there comes the other social challenges as well, which are the poverty, high employment rate among youth, especially among young population, ex-detainees. These are all the barriers that it makes them even more vulnerable, and they are prone to the high-risk behavior, which is manifested to increased trend of the prevalence of sexually transmitted infection, HIV, absence of control, reproductive control, social isolation, violence, and etc., etc. So what we're looking on the data, recent data, what we have from the mix, only 11% of the young people age 15-24 have comprehensive knowledge about HIV prevention. What it means, they only 11% know what are the 3 ways of transmission of the HIV transmission. So in this age group, only 33% knows place where to get tested for the HIV, and 60% of them have discriminatory attitudes toward the positive, toward the people living with HIV. So this is just evidence in the table how we're positioned, how Georgia is positioned in terms of the UNAIDS 1990 targets achievement, what we talked about, that in terms of second and third targets, viral suppression and the treatment were positioned very well, but unfortunately for the HIV prevention, for the detection, we're a little bit behind, and of the estimated number of people living with HIV, more than 1/3 infected, they're still not aware of their status, of their HIV positive status. And this is a compilation of the data from the different surveys. What is the utilization, the testing rates in different groups over the 1 year. So we have different target groups here. We have drug users, we have sex workers, MSM, and we see that it's quite low, their usage of this HIV testing. So why we decided to start to work on this project? What is important about it? What is behind behavior behind this low testing update, low demand of the testing among this target population? So now we have opportunities for behavior changes in the population who are in the risk, and especially young people. We see that there is a changing nature of multiple of challenge to be addressed, called diversifying approaches, and to tackle them from the different perspective. We have an opportunity to do the research and combine quantitative and qualitative parameters, and to have this in-depth analysis and to look for the root causes, and after translate this finding into the policy and into the actionable solutions to change behavior, and develop and launch effective behavior change communication strategy. Behavior, what is behind all these root causes. So how we started to think about this joint initiative. As UNFPA is leading the HIV joint team, UN HIV joint team at the country level, and is represented in the CCM, in the Policy Advocacy Council, and we have a wonderful strategic partnership with the government, with the community-led organizations, with key populations, with NGO. So we look at these challenges, and we see that there is a behavior challenges. We have a low demand, we have a low uptake. So partnering with the UNDP, inviting UNDP to work on this project jointly, we started to think how to measure the behavior change. So this is an post-intervention perception studies and RCT to identify the barriers and the ways of overcoming them to increase the HIV testing. And my colleagues from UNDP will talk about this RCT design. And we focus to conduct initial surveys and explore the perspective of different target groups to look on this problem from the different perspective, from the perspective of young people, from the perspective of key population, young key population, healthcare providers, to see what are the interactions between them and to understand what are the perceptions and barriers and why we have the low level of testing uptake at the country level. Following these findings, then to follow up with a communication campaign and propose the changes in the service design, propose the changes with the target groups, and to increase the uptake of relevant services, including the early HIV testing. So what we did, the qualitative study, which was based on the social cognitive learning theory, to identify the barriers, including the gender aspects that hinder target population from using HIV testing services and contribute to the late detection. So the study was focusing on two main specific objectives. So study individual and structural barriers that stipulates low demand and referral to HIV testing, and study the local context and context relevant and related knowledge regarding the behavior, options, perceptions of specific groups, and these specific groups are young people, including vulnerable, including young population, key population itself, healthcare providers, people living with HIV, and drug users. So in general, the study was conducted in 5 biggest cities of Georgia, focus groups, which covered the focus group discussions and which covered the in-depth interviews. Methodologically, this data was processed in Atlas software, and the findings, will continue with the findings, what we have. So these are the criteria, first of all, what we have applied while analyzing findings of these different target groups, and we structured in this way that perceived vulnerability. We were asked what is the perception about the target groups, that how they perceive the itself this problem, itself the high risk behavior, itself the importance of the testing, importance of utilizing this. So most members of the high risk behavior groups objectively assess that there is a risk of the HIV infection, though they have not been tested. They know, but they don't have any behavior to go and test. So this is assumed that we have a right perception among the key population, but still they don't have a proper behavior to go and to test themselves. There is some other factors that have an effect on their decision. So how they perceive the severity of the disease. Again, they have an information, but fear for the diagnosis is very high. So this is a psychological context, this is a social rather than the health issues, but still diagnosis is more related with the stigma and discrimination. This is in a fear that how the family, friends, and society perceive their status. They have a fears with employment as well, with some restrictions. Here comes the timely testing. Majority of the respondents, they're very well informed about the benefits of the timely testing, but here comes that what they think that acknowledging of this effectiveness of the timely treatment might become the motivator factor, and they think that they recommend that the more awareness and the information sharing is important in this regard. Now the barrier of the testing. Numerous barriers have been identified during the studies, and this is a insufficient awareness regarding HIV and related services. Stigma and discrimination comes in every aspect of this research. Distrust, unfavorable environment, fear to breach the privacy, indifference, sometimes judgmental attitudes from medical personnel towards especially with a high-risk population. Some of the groups have a limited geographical availability of testing as well. So all these are the barriers that negatively affect their motivation to go and to test on time. There are some barriers, of course, with the physical geographical accessibility in terms of the regional inequality. Respondents point out that testing services are limited for those people who live in rural and small towns. And here comes the issues of the privacy in small towns especially. Knowledge and attitudes from the medical personnel. This was an interesting findings as the findings vary from institutions to institutions. That part of the medical personnel speaks openly that the healthcare sector and medical personnel is not still ready to provide the friendly services to people with, they call it different marginalized behavior. But there's still some good findings that some personnel are ready and they acknowledging that their behavior should be stigma-free with the high-risk population. Standard procedures. So here comes that the privacy and confidentiality issue are in most cases violated when they are reporting to HIV results. So their medical personnel itself is not aware how to notify HIV personnel in right way. So the root challenge here comes from some legislative gap, and there still, as there is no clear communication standards, how these notifications procedure should be completed. Infrastructure inadequate for testing. Here comes as well that we're talking about the quality friendly services, that non-private environment, waiting time, sanitary and hygienic norms, that was the issue that was emphasized, and attitudes and lack of motivation among the primary healthcare personnel. So when we're talking about the quality of the services provided, this is the lack of motivation from the healthcare providers, that what is the attitude of the personnel toward the HIV screening? Here are some differences as well. Some of them perceive that the screening program is just of the part of the services, and as they are not, their workload is increased and they are not paid additionally. There is lack of motivation about the healthcare providers to provide these services, and it's somehow has a negative effect on the quality of services. So these are the main findings from these two perception studies, which we structured in this way. And also we added some quantitative data while analyzing this qualitative survey that complemented to this study, that in terms of the different target groups, what we have, the challenges, what we face in reality. So we have data from the mix as well, that what is the knowledge, what is the attitudes of the young people toward the testing, what is the discriminatory attitudes toward the people with the HIV, living with HIV. So young people and adolescents, we see that only 11% have a comprehensive knowledge, only 33% know where to go to do the HIV testing services. So a very small percent among young women and men have been tested for HIV, and 60% reveal the discriminatory attitudes, which is quite a high percentage of people who show this discriminatory attitude. So I will go through these main findings as we are running out of the time, and we have in a key populations findings here that the rates we were comparing these 3 different cities, which is where the research was conducted, that rate of the HIV testing among people who ingest drugs difference is different considerably by the city. However, the average countrywide data show that despite an increased risk of infection, only a third have been tested for the HIV, which is of course low. For the majority of the key population, the fear, what we have mentioned already, of being infected with HIV is more related with the physiological and social context than the health issue. People living with HIV, still the low detection remains a significant challenge in Georgia, and only more than 1/3 of the estimated number of people know about, and they are not aware about their status, their positive status. And the barriers are that the expectation of negative attitudes, the fear to have an HIV status, and HIV positive respondents reveal that their attitudes towards HIV/AIDS before and after being infected different. They mentioned that this fear and hopeless have been replaced by rational perception of the reality, and they state that this kind of change is the result getting more information about this disease. In terms of the healthcare professionals, what we have mentioned, that from institutions to institutions, their perceptions are different, but still there's some interesting findings that they think that the majority of the healthcare professionals, they think that there are no barriers in the system. The medical institutions they have represent are free from stigma and barriers, and they are ready to provide quality testing and counseling services to representatives of the key population. This is interesting how they perceive even the stigma and discrimination and the services, how they are providing. However, according to the majority of the service receivers from the key population perspective, the attitudes of the medical staff toward them is indifferent and unethical. In the better scenario, that they are indifferent. In worse scenario, they mention that they make us feel like we are unwanted patients. So independence at the times, judgmental attitudes from the healthcare professionals toward the healthcare population and the people with HIV have been identified as one of the important barriers to HIV testing. And about 85% of the key population state that they would recommend a friend to visit non-governmental organization for the HIV, for the testing rather than private healthcare providers. Only a very small percent recommend these services available at the medical facilities. So these are the very, very concrete findings from these researches that we are stressing today. And based on the findings, what is our role? How we will translate these findings into the policy work, how we translate these findings into the recommendation that needs to be translated into the actions, translated into the action that will be implemented. So why it's important. So these findings gives us the clear picture and opportunity to see that why it's important to develop and launch effective behavior change communication initiative in order to increase the demand and in order to increase the uptake of HIV testing among young people, among key population. And just in general to mention that we as a UN, we as a UNFPA, our priorities are in line with the other partners' efforts being well positioned to lead the advocacy and provision of technical assistance within the framework of HIV joint team that relies on the complementary individual capacities from UN agencies and our strategic partnership with the National Center for Disease Control, strategic partnership with the Ministry of Health, and all these important stakeholders who are involved in the HIV prevention development portfolio. So this is an added value of UN. It's quite a multi-dimensional approach we use, and our collaborative efforts, and we're actively involved in the policy work to provide the technical assistance to advocate how to make this research and these findings reality, translate it into the actions. And we are very well acknowledged to be the major agency to promote the human rights services, and that will be based on the human rights and advocate for the sexual reproductive health and gender-based violence with a focus on young people and vulnerable populations. So the partnership in line with the priorities of the government and civil society and academia. Thank you very much. This is very brief.
Thank you very much, Natalia, and I hope that I'm still online. And before Zoom kicks me out again, I want to thank the whole team for being, and everybody, all the presenters for being extremely kind of supportive and mobilized to take over. Before Zoom disconnected me, I wanted to thank our colleagues from UNFPA for excellent partnership, for the funding provided by UNAIDS UBRA funding, and for our colleagues from Istanbul Regional Hub HIV team who, from both ends, UNDP and UNFPA, who have been extremely supportive to this initiative. And of course, to the joint team on the ground, the work has been extremely exciting. And I want for all our partners to know that we are really engaged in this work. Before I hand over the presentation to another presenter, in the chat window, I sent you a link to the research, alternative research micronarrative study. I can share briefly the screen and show the results. One of the, as Natalia already mentioned, one of the ideas that we are trying to promote is, I don't have screen sharing option activated, but one of the idea that we are trying to promote, how to bring the research close to making it actionable, is also to share the data, also to give access of whatever we learn, whatever the research shows, so that the same data, the same information, whatever people have told us, the narratives are accessible to all the parties, whether it is people themselves who told us the story, whether it is decision makers or any other. For that purpose, the results of the micronarrative survey, which we conducted together with our expert Anna Hanchar, and Anna is with a small baby, so she will join whenever she can. We all work from home. So this is the visualization that we produced. Can everybody see the screen? This is at the moment in English, but the stories are in Georgian. So this shows the questions that we ask the participants after requesting them to share their latest experience of HIV testing, or for experience of somebody they personally know. And each line represents each answer that people gave. So if we click on the answers, we can say that this particular story is about judgment, being judged for example, public opinion, what people will say if I go and do the testing. So this is the story. So it says that my friend and I decided to get tested for HIV, but we got mindful of public opinion and we didn't do it. Ultimately, we didn't do it. The person who is giving this story is, and we can see, is female. She's 18 18, 24 years old. And these kind of things, as told by the respondent, happen often. If I scroll down the window, I can also learn more about this person. This was the reason for her decision to have testing done. She was motivated because she's generally worried about HIV and wants to know her status. She didn't get any advice from any friend in this particular case. It was her own decision, and she ultimately didn't take the test. The person who told us this story is also female, 18, 24 years old, single, Georgian with incomplete higher education, living in urban areas of Kartli. And we can have this kind of information on almost every story and every respondent. So when we speak about making our research actionable, this is what we mean. We also give it, this is, for example, the stories about fear of getting testing and understanding the results. So to make what we learn actionable, we don't only work on designing the interventions ourselves, but we also are very much motivated to give access to data firsthand to the people. Confidentiality issues are absolutely taken care of. All the respondents who answered the survey, they were confidential. It was online survey. And also the stories that people marked not for public sharing are not included. They will not be visible. It will be marked as not for sharing, for example. But those of you who are interested to see what were the results of the narrative study, you can go through this and have your own analysis done as well. Some of the findings that Natalia presented were very much the same as we had it in our research. If Anna is able to join us later, she will be able to share, but I can mention several of them. The proximity of testing services was of importance. The age of the respondents was important. NGO service provision was preferred over other terms of services, and I guess Anna is ready and she can take over and give us a fuller account of how the process is, what is methodology about, and I guess you can enjoy the results later on. Yeah, Anna, shall I hand it over?
Yes. Hi, thank you so much, Fatina. I'm so sorry, everyone. It's a bit of, one of those days, but I will try and do my best to give you an idea of what we have done in relation to the narrative research. I'm not going to take too much time, so hopefully we will have time for some Q&A session later. So what I will do, I'm going to share my screen now so that you can see my presentation. And I am going to go through the very basics of our methodology, and I will touch on the results. It was actually very interesting to hear Anna and Natalia speak earlier on about what we already know and what has been, some of the observations from the study, because what I see in the data really speaks to the findings and observations as well that I've heard about earlier on during this call. So let's start. I'm just going to start the presentation now. And basically what we have done, we've used a narrative research approach to understand how people perceive testing services in Georgia. What we've done, we've used the narrative research called SenseMaker, which combines narratives, as in stories, and quantitative data in order to get a more comprehensive picture of what is happening. So I'm just going to start with a brief descriptions of what stories or narratives give us in general. So it's kind of well known that personal stories and personal perceptions are memorable anecdotes that reflect how people perceive the world. It shows what people feel. It shows how people react to things. It gives the perspective of a person as opposed to just the general population. It's quite an effective way of summarizing key issues that are important to people in a very short, effective way that is very easy to relate to. It is something that appeals really well to policymakers or people that work in project teams or even in general population. And therefore, we quite often refer to or kind of like to use this approach because it serves as an intervention. When we talk to people and interview people about certain issues, they kind of start to think about those issues a little bit more. So that is kind of another point that I wanted to make. Also, stories and personal narratives help to build popular interest as well. So they do serve as evidence quite often. At the same time, although they still are anecdotes and they still are quite personal. So what we do in narrative research is we try to scale up and we try to kind of systemically collect large number of narratives about a specific issue. And I just want to read a quote by a guy called Dave Snowden, who came up with this narrative approach, which summarizes really well why we combine those kind of narratives with large-scale quantitative data together. So the quote starts, while numbers are useful and can be objective, they are rarely persuasive by themselves, as they lack the rich context of anecdotal data. While anecdotes can be very persuasive, they lack objectivity and can be very easily dismissed. So what is needed is an approach that combines both and merits of both, the objectivity of numbers and the explanatory power of narratives. So I'm just going to move on to another slide, if the system will let me. Yeah. So what do? We start with the story. So in front of you, you see a story which we collected from a young person who is residing in Tbilisi. She's 24 years old. She has higher education and she's not married. She shared this story just to, as a response to a prompt. I'm so sorry. Yeah, she's okay. As a response to a prompt where we asked her, well, think about anything you know about HIV testing. Is it your personal experience? Tell us an experience of someone else you may know. Just whatever comes to your mind. So that prompts some memory. And that's what she said. And then we asked many other people. And then we collected many other narratives. And they were all very, very different. And then we asked more people and more people. And then we asked these people to map their stories along a preset dimensions or preset maps of concepts that were of interest to us and were quite relevant. And those stories were reduced to data points and were mapped on different scales. And in front of you, you just see an example of one of those scales. So what we see is that the first person I mentioned, her story falls in the lower left corner. And this is the corner that tells us at a very high scale that she is telling us that her problem with HIV testing is about accessibility of testing services. It's not about awareness as such, it's not about confidentiality, it's about accessibility. And that's how we take those individual narratives, contextual narratives, to a very high level, high scale, where we can read the patterns and understand what's happening at that higher level. So that's effectively is how we approach this. And that's what gives us that scalability, that high level vision, that high level view, as well as the context of the narrative themselves. So the approach has been used in public and private sectors throughout the last 10 years. And kind of addresses the whole range of issues. So people used it for citizen engagement, for women entrepreneurship issues, for healthcare issues, for political engagement. So the whole broad spectrum, and there is a whole set of literature that kind of speaks about how it's been used in academia and management literature and strategy literature. And also there are some very interesting case studies out there that kind of talk about how people found it useful to combine narratives with the quantitative data that was captured along with the narratives as well. So I'm just going to very briefly walk you through the study and what's been done, and then I'll move to walking through the results very briefly again. So the objective I've already mentioned, it was about understanding HIV testing experiences, and the key points that I wanted to highlight, the first one, the engagement of the project team was something that we benefited from throughout the whole process. So that was a really, really nice and useful engagement for us to have, because we got that nuanced participation, value from nuanced participation of people who know what they're doing and of people who know what they want to get at the end and who would understand the data. The collection was done remotely throughout July and August 2020, and 250 people were interviewed altogether, and they were broken down into the general public respondents and target group respondents, so that we could compare whether there is some kind of a difference across the two groups, not just in their narratives, but also in the patterns of their behaviors or their views or their perceptions on HIV testing. So what came out of it is the interactive infographic that Hatuna shared with you earlier. And also we've done some more structured data analysis that summarized kind of the main observations and allowed us to make some conclusions that hopefully will be beneficial for the work going forward. So the three areas that we managed to group the findings into were the motivation to get tested, the testing experience, and the awareness of HIV-related issues. And those were kind of the three umbrella terms. Under each term, we have a range of findings, but I'm not going to go through them in too much details. I just want to highlight what we've seen as a very strong observation in each of the three kind of umbrella terms. So the motivation to get tested, three things emerged quite strongly. The first one is that if people get tested, or if they make a decision to get tested, they very rarely follow advice of people that are close to them. Usually it's someone who is either a friend or an acquaintance or a doctor or someone they know via some network. So it's not a family. The second thing that we found interesting was that age played a huge role in how people perceived the willingness of other people to get tested. So for example, we were interested in the setting dimension, where we compared whether people from urban settings feel different about testing compared to people from rural settings. And in fact, most people don't, but if they do, it's due to age. Another finding was that accessibility of services, and this is what Anna said previously, is the most important deciding factor for people to get tested. So we've compared it with the confidentiality issues, so how strongly people feel about that, and there are people who feel very strongly about confidentiality. Also awareness of testing services was another thing, but the majority of the respondents felt that accessibility is the issue. And if we go back to the example of the story that I mentioned before, she talks about free access to test services. And that's what she means by accessibility of testing services. So that's how narratives come into play when we're unpacking the concept of what do people mean when they tell us that accessibility is the most important thing? Well, to her, to that person, the cost, what she means. Also, an interesting thing here was that the target group was mostly talking about the awareness, where the rest of the respondents were talking about the accessibility. So that is another slice of the data that came in as quite interesting. Another umbrella kind of area for the observations was the testing experience. So how did people perceive their experiences if they decided to get tested and went ahead with the test? So the speed was, if people liked the experience, speed of testing was the most liked aspect. The non-government testing providers received the highest rating. So we had 4 service providers or testing service centers listed as options for people to choose from. And it emerged that non-government service providers received the highest positive ranking compared to other service testing centers. And also the choice of the testing service was dependent on which route or how people got to get tested. So was it a medical professional who advised them? Was it a friend, or was it an NGO? So that route kind of defined the testing center that they chose to go to. And it also seemed to have a relationship with the positive or negative experience of the testing process itself. And also another observation was that the staff attitude is quite important in making it easy for people to get tested. And again, we've compared this with the physical experience and the possibility of self-testing. And staff attitude just came across all groups as being really, really important, and quite strongly so. And the last set of observations kind of falls under the awareness of HIV-related issues. And here, a huge interest was built into the notion of knowledge of causing potential harm to others. So do people understand? Do people know? Do people care? And what we see is that people generally tend to know about the implications of HIV or AIDS, but they know a little bit less about causing potential harm to others. At the same time, there is a big difference between the two groups. We compared young people, as defined as people younger than 25, and older people as an age group of 25 and older. And what we see is that younger people know less or report less about causing potential harm to others compared to older generation. We don't know why this is the case. We can only assume, and we did make a couple of assumptions trying to explain that finding. But again, this is just something that emerged quite strongly out of the data. So I'm not going to go into our findings more than this. So I'm just going to leave you with this information. And I'm going to stay here obviously for the Q&A session as well. So that's all I wanted to present to you today, and hopefully that will give you a nice idea of what narrative research is and what kind of things we managed to see and pull out of the data that can be workable, actionable, and interesting to bring forward. Thank you so much.
Thank you so very much. I didn't introduce you properly. Anna is a doctor of science, and she's been working with the authors of this methodology with the organization Cognitive Edge, for projects and international organizations. We've worked together at least on 6 projects in different countries, and she has also supported our research on gender-based violence within the framework of Czech Supported Initiative as well. So I'm very happy to have her on board. We are very not little bit, but quite over the time limit. And I'm happy to hand over the presentation to our next team of experts. We are loaded with presentations today. And if you don't mind, we'll take extra 15 minutes if you have time in your schedules and agenda, if that is okay with you. Because what comes next is our expert, Dustin, who joined Keti Gomelauri, our behavioral expert on the ground. And what they're doing together is they are taking stock of what we've learned in this researches conducted by UNFPA team and Anna and our team together, and incorporating into and testing a solution kind of intervention to test what would be the best way to help improve uptake of testing services in Georgia. Dustin, over to you, and you can present your credentials, I guess, yourself.
Thanks so much for that introduction, Khatuna. And thanks everyone for being here today. My name's Dustin Gilbreth, and I'm the Deputy Research Director over at CRRC Georgia. And today I'm going to be talking to you about randomized control trials, and specifically, as Khatuna mentioned, taking some of the findings from the past two presentations and then putting them into a new trial. And so by way of doing this, and in order to do this, I'm going to spend a bit of time talking about what randomized control trials are. And from there, I'll give some examples of randomized control trials which have been conducted in Georgia. And afterwards, I'll put forward what we plan on testing at the moment inside of a randomized control trial aimed at increasing HIV testing uptake, particularly among young key populations in Georgia. I'd emphasize that this is really a work in progress, and we're just at the basic level right now. I think yesterday I presented the first full design of it over to Khatuna, and now it's being reviewed. And so your input is more than welcome and very much appreciated if you have any ideas or thoughts. In this regard, I just want to appreciate or say thanks to all of you for staying on for this presentation, if you can. So the first thing, what's a randomized control trial? The most important thing to know about a randomized control trial, if you're not going to be implementing one yourself, is that it's about cause and effect. You want to find out whether your intervention made something happen. Did it push the needle? And the question you might be asking is, well, why don't we run a correlation analysis, or why don't we see if things change just before and after our program? Well, correlation is not causation, and I know it's almost trite to say, but everyone says it, and still we see lots of people claiming correlations are causation. My favorite example of this is this chart. And this is a chart from a book that was published about 10 years ago. And it shows the correlation between the number of people who drowned by falling into a swimming pool and the number of films which Nicolas Cage appeared in. They're pretty strongly correlated, a 67% correlation. But as we would hope and think probably, Nicolas Cage films are not going to be causing any increases in swimming pool related deaths or drownings. We hope strongly at least. And so at this point, you're probably asking, what is this randomized control trial and how can it go beyond correlation? How can we avoid the Nicolas Cage problem seen in the last slide? And what we do inside of a randomized control trial is basically create two groups who on average are very similar to each other. And we do that through randomization. And when you randomize from a list of 2,000 people and 1,000 people get one thing and the other 1,000 people don't get the other thing, we end up with two groups who are very, very similar, except for that one thing. So the one group got the treatment. So this is the methodology that's commonly used in medical trials. I think all of us probably saw the results of the vaccine trials for COVID recently. And those are results, the 95% effectiveness from a randomized control trial. In the current context, we can also do these kinds of things with policies. And so there's a few policies that have been experimented on in Georgia to see whether or not they would work. My personal favorite among these is from the Safer Transit Options for Passengers project. I think everyone on the call has probably been on a marshutka at some point or another in Georgia. The general perception of them is that they're a bit dangerous, and that perception is borne out in reality. And so to try and solve this and get marshrutka drivers to drive a bit safer, what we did at CRRC Georgia is we got the list of all marshrutka drivers leaving Tbilisi, and then afterwards we randomly sent people to half of them and told them that, look, we're doing monitoring as an NGO of safe driving, and you, if you're the safest driver in the country that has a route outside of Tbilisi, we'll give you 50 lari gas voucher. And by the way, we're not going to tell you, this time we told you, but sometime in the next month or so, we're gonna come back, and it's not gonna be me, it's gonna be somebody else, and they're gonna see how you're doing. And we'll base the judgment based on that of whether you're the safest marshrutka driver in the country. As a result, what we observed was that dangerous driving behavior. So in the first round, when people didn't know they were being monitored, some of them drivers didn't know, 96% of them engaged in some form of dangerous driving. But when they knew they were being observed, this declined by 26 percentage points. Similarly, with illegal passes on the road, 79% of drivers engaged in some form of illegal pass. But when they knew they were being monitored, this declined by 36 percentage points. Then, when we later went back a few weeks later, and they didn't know that they were being observed, we saw a 15 percentage point decline in dangerous driving behavior. So that's the marshrutka trial and the safer transit options for passengers. Another more recent trial that was run by my colleague Kedi Gomalauri at IRC and also working with us on this project for UNDP was on parosana, the brown marmorated stink bug. And so the National Food Agency has this hotline to try and help farmers if they have any issues spraying for the stink bug. The stink bug has been this big problem in Georgia, particularly for hazelnuts, the country's largest cash crop, which just came in a few years. And it's a really technical process to try and spray properly and monitor traps that have stink bugs in them. And so this hotline was set up to help people spray properly, monitor traps, etc. But people weren't calling. And so what Keti did was, and together with a team from the Behavioral Insights team, they designed this infographic. And they randomly selected, I think it was 150 villages in Samigrelo and Guria. And they put this infographic up in about half of them, and then the other half didn't get it randomly. So it was a randomized control trial. And the results of that were a 12-fold increase in visits to the hotline. And so this is like a super cheap policy, hanging up posters that leads to a very large effect and very large improvement potentially in the fight against brown marmorated stink bug. So here's just that second part of the infographic with the phone number and information about what you can do. And then finally, just this end of the infographic. It was all one, but it didn't fit on one slide. So a very visually appealing infographic overall, which is always helpful. So these are two success stories in many ways of policies that worked, and they were shown to work from randomized control trials. A third one that I recently ran and I wanted to include here to emphasize why it's important to actually run a control trial and not just come up with good ideas, but to test those good ideas and see if they work. During the lockdown this spring, so I was running a weekly survey asking whether people were leaving the home and socializing. And so as we can see on this left-hand chart, it was increasing week by week by week by week, and more people over time were doing this. A common tactic in the behavioral science literature is to tell people what the majority of people were doing. And by doing so, people often start doing that same thing. And so what we did is randomly told people that, so we did it during this wave of the survey, but at the time our latest data was here, was that a majority of people were staying at home. And then we asked them whether or not they too would stay at home. And the results were actually the opposite of what we wanted. So more people said that they planned on going out next week. So 18 percentage points more said that they were going to go out next week after hearing that most people were staying at home. The opposite of what we would normally expect on situations like this, suggesting that this would be a very bad idea to implement on a national scale. And so it's good that no one did this. No one actually had a national campaign trying to do this, and that it was tested beforehand to know not to do this. So that's what a randomized control trial is, as well as a few examples of randomized control trials that have been done in Georgia. Right now, I'd like to transition to where we're at with the RCT design that Ketty and I are working on together with Khatuna and some colleagues at the Behavioral Insights team and UNFPA as well. So what we want to test is first so advertisement and sort of a social campaign that would be done on Facebook or maybe Instagram we're thinking about now, based on some meetings with young people that we had this week. And we want to test whether saying that we have a set of doctors who are sensitive to the young key population's concerns about getting tested, and actually find those doctors and give doctors specific training or service providers on those sensitivities, so that young key populations actually do feel comfortable and more comfortable whenever they are at a getting tested. And so we would advertise that fact, and we would randomize on Facebook whether people saw this sort of message saying, we have these sensitive doctors, find out more how you can get tested for HIV here. And then we would have sort of just a standard message, find out more about HIV testing, find out where you can get tested on HIV, and randomly assign who sees that. Afterwards, if people click on that advertisement, it would lead to an information page that includes a hotline number. And we would set up 2 hotlines right now as the idea. And one of those people, the hotline operators will be trained to give people a special script that helps them plan the day for when they're going to go and get tested and encourages them to go get tested. This is something that may sound small, but there's lots of studies from around the world showing that things that are as simple as going to vote or going to the doctor's visit, if you have a concrete plan about each step inside of those, then people are more likely to actually follow through with the appointment or go to the polling station. And then after that, for this group of people who gets that encouragement and that plan, we want to send them timely reminders to go get tested. Respecting the fact that people are very concerned about confidentiality, as was discussed in the last 2 presentations, we'd actually send a coded reminder that the hotline operator would tell them. Something like, get the best deal on Apple products today, and then so the clinic's location, the address, and then the time of their appointment. With that, we would also have plans developed for service providers so that they could help the young person or the person in the treatment group plan how they're going to come back and get their test results. Because as we've heard previously, people are often afraid of it. And so again, with that plan, we hopefully will encourage more people to come back and find the results. And finally, when people get the results, the idea would be, or when the results are ready, to send a timely reminder to help people remember to go and get those results and potentially get tested again. So thank you so much for listening. That was my presentation, and during the question and answer period and the panels coming up, I look forward to any comments and thoughts on that in particular. So thank you so much.
Thank you very, very much, Dustin. With this, we are really closing our presentation part, and we have practically very little time for discussion. But if you have 15 minutes to spare, we would be very much interested to have your questions, comments, suggestions. I know that on the call we have a group of students who helped us with the data collection. And I hope that we also have paralegals, somebody from the paralegals team from Tanat Goma group, who was also part of the data collection process. to hear your impressions, suggestions, advice to you. So I'm handing over to my colleague Karla Koutková for moderating this session. And thank you very much once again for sticking. We haven't lost a single person from the call so far. Thank you very much. Karla, over to you.
Thank you, Katuna, and thank you to our presenters as well as all of our dear Roundtable participants. Thank you for staying with us. I just wanted to remind that this is a research for policy roundtable where we are actually endeavor to connect the two communities of researchers, scholars in Georgia with practitioners, with policymakers. And it is very important for us that we stimulate a discussion between you so that you can exchange your expertise and you can sort of see how to use the methodologies that were innovative methodologies that were presented to you today. So I wouldn't want to delay anymore the plenary debate that is ahead of us, and I wanted to encourage you, if you have any questions for our speakers as relates to their presentations. We heard Natalia from UNFPA giving us the latest details of their semi-structured qualitative research conducted together with a partner NGO on HIV. We heard Dr. Anna Hanchar presenting on the exploratory power of narratives in doing research on HIV. And finally, Dustin giving us the overview of the current RCT initiatives planned for next year. So I would like to encourage you to either raise your physical hand or write a question if you have in the chat box, so that we can address it to the. Please don't be afraid to speak up and address our speakers. We know that very much feedback is appreciated both on the UNFPA initiative, on the recommendations that Natalia mentioned. So if there are any practitioners, it would be much appreciated. Also, as regards to the last presenter, Dustin, who is planning an RCT intervention. This is a very innovative endeavor in a policy research or in policy practice. As Katuna mentioned, we actually, there's something important that we wanted to mention, which is the community building aspect of conducting mixed methods, micronarrative and RCT research. Which usually comes from employing or engaging students, young people, to actually conduct and disseminate the questionnaire, collect data. So it would be also interesting maybe to hear, we have, I believe, on board 2 young students, 2 young people who helped us to actually question and disseminate the studies, to share their experience and to tell us how it was to actually question people about issues such as stigma, HIV, and discrimination. I believe, Katuna, you will know who the volunteer.
Hello.
Yeah.
Hello. Can you hear me?
Yes.
Hi. Thank you for your presentations. Very interesting. Well, I was a researcher. I was participating in conducting this research. I'm a student at Tbilisi State University, and I had this wonderful opportunity to participate in this research, as I mentioned already. And this research was conducted online. And personally, to share my experience, well, it was very valuable for me personally, and also for other people, I guess, as well, as I've raised the awareness regarding this HIV issues, and I've made some posters as well, and I've posted on social media because young people, young generation in Georgia usually use social media very actively. And well, personally, I posted this link in Facebook groups. We have this Facebook groups for women and also for men, and we made this special email as well to have this direct relationship with people who maybe didn't want to participate like they in directly and wanted to share their stories anonymously. So I think that was also an important part while I was doing this research. And it was very valuable, and the results that we have and that you presented are also very interesting. And I think that this behavioral studies will be a great tool to implement the policy, the right policy, and to share them with other nations as well, I think, because the HIV issues are very, very important one for the future generation. Thank you.
Okay, thank you very much for sharing your direct experience from actually doing the field work, doing the very hands-on work of distributing the questionnaire, and also being the very important pioneer out there to spread awareness by doing the research actually about HIV. Not seeing question coming from other people, I might actually pose one myself that might be of interest and importance, I believe, to both communities that we have here. Anna and Dustin were actually presenting on two segments of a mixed methods approach, combining micronarratives and randomized control trial, which is still not very widespread in policy practice. So I'm wondering, how can this actually, Anna and Dustin, help practitioners in their day-to-day work? And what is the added benefit of actually combining these two methods? If you are ready to address this question, please go ahead.
Dustin, do you want to take this one, or I can probably start and then?
Yeah, no, go for it, and then I can follow up.
Yeah. So from my experience, mixed methods approach work really well if they fit together. So basically, the way that I saw this working in the past was the narratives helped to clarify RCT messaging. So it's not about, first of all, it's about which routes may be useful or more efficient, but it's also about, so it's about what we need to do, but it's also about how we do it and how we're phrasing this. So our previous experience of working, of connecting micronarratives with RCTs was in relation to the intimate partner violence study. And one of the findings, or one of the things that we saw in the narratives that helped to shape RCTs was, for example, the informal way or informal networks of people that are not very close to the respondents or to the victims that help to spread information, right? And help to act and help to make decisions. And this is something that wasn't evident from the data, and there was a lot of kind of the high level data. So we knew that informal networks work. We knew that sometimes people don't feel very comfortable by talking to their close family. And again, this is something that is quite relevant to this study too, as a finding. But we didn't really know what is it that would help people, right? So we knew what didn't work, but we didn't really know what would work. And when we dived into the narratives, we could find the phrasing, we could find the angles, we could find the things that people would listen to because they themselves shared it with the audience, if that makes sense. So to me, the benefit of this experience, of this particular experience, was kind of twofold, just to summarize. The first is to understand what routes can be taken in order to make people act. And second, what kind of things can be, what kind of wording, like down to the wording, what kind of communication can be shared with people to prompt them to act and to prompt them to change their behaviors. So that's how I saw the value of the mixed method approach here. Yeah, I'm sure some of the findings, maybe Hatuna knows more about this, some of the findings are probably public, and I'm sure there's some kind of a report that people can access. But to me, it was quite a huge value that came out of the narrative studies specifically.
Thank you very much. I think I would add here, I wouldn't want to continue too much because we are also over time, but I think the whole value of this work that we have been piloting the second year now is that it doesn't start with the data. It starts with community building. It starts with bringing the platform of actors together. It is about UNDP working with UNFPA, UNDP bringing the exploration, these narratives, RCT, etc. experience to couple with the UNFPA platform of NGO actors, government actors, community that they have already working on this theme, HIV. And we also add to this the element of service development and service delivery, and that the design of our city is also thoroughly collaborative. That in this process, yesterday, for example, we had a meeting in RCT design, we had the whole community part of the discussion last week. Yesterday, we spoke with the team of young researchers to go through what would be the relevant communication channels. And on Tuesday, we will have another meeting with the community members to finalize the RCT design that Dustin already presented, outline of it, which he already presented. So if any of our young scholars would like to contribute to this discussion from yesterday, I would be happy to hear them as well.
Hello to everyone. I'm Tati. I'm one of the young researchers, so experienced this great research, and thank you to you all, because it was really great experience for me, significant experience for me to take part in this research. And before I talk about communication channels, I would like to talk about what findings I have during this research. For example, when I was posting this link about posting the topic of research in some groups, there were rare people who were ready to take part in this research, because we have some stigmas, as we know, and as Natalia said during her presentations, and this stigma we have this time too. I'm sorry for my English, and maybe I have some spelling corrections to correct some spellings, and also, but when I was directly messaging them to Messenger or some other channels, communication channels, they were open to take part in this research, and they asked me if it was closed and no one could see who was filling these applications, these research applications. And it was my findings, and I wanted to tell you about this. And what about communication channels, as Hatuna mentioned? Yes, we had yesterday some discussion about what communication channels would be better in Georgia, and we thought that we discussed that, and we agreed that it is better to use some social networks as Instagram and Facebook, as the younger young generation use most of this kind of social networking. And also we thought that it would be also good to have some talks during on TV shows which are on daytime. I don't know what it is called. day show and morning shows, because sometimes we look through this TV shows, and they are posting on Facebook too what was main in this topic. And we think that it is good to use all kind of communication channels to get rid of stigma what we have now in Georgia. Also, we thought about some kind of booklets. Can you help me with triplets? Yes, to have in some places where youngers are surrounding, also in clinics where we have to wait for our queue. So this was the main topic of yesterday's meeting, and I think Tatia will also continue my topic. Thank you once again, and I am really appreciated with this all the communication with you, starting from the research and now for now.
Thank you so very much, Tatia. Thanks a lot.
Thank you, Tatia. Thank you very much for sharing with us. And actually, as we are running out of time slowly, and people have other obligations, I would like to ask for maybe final round or final comments. If you have maybe something to add or wrap to everything that we heard about today.
I just wanted to add with Tatia and the other Tatia about yesterday's, we had this call yesterday about the RCT design. And one other important factor which was mentioned was in the communication strategy, small videos that we often see on social media. So mainly what young people said was that they don't want a lot of huge information, huge texts, and usually what their attention is more focused on are these small 2, maximum 3-minute videos that show up in the social media, and something that's really memorable. So that was another important factor that was mentioned yesterday during the RCT design with from the youth.
Thank you very much, Sopo. It's fantastic to hear about the educative element and community element of the RCT intervention as well. I'm wondering if there are any final comments from anyone, but not seeing any raised hands. I would like to once more thank everyone for being here today. Of course, Zoom, as any technology, can fail us sometimes. So thank you very much for your understanding and bearing with us. It's been a pleasure to see many already known faces and names on our Research for Policy Roundtable. We've been continuing with this initiative since last month, and we will do so next month again with another interesting topic that is relevant very much to both researchers and practitioners in the COVID pandemic. And I'm wondering if maybe Katuna has any final words and thank yous to share to everyone who's been here today. No, unfortunately, it seems that Zoom is failing us once more today. We've been dealing with quite some technology issues between Georgia and Czech Republic. But thank you very much, Dagmar and Anna, for being here with us today and opening our very interesting discussion. Maybe Anna wanted to share. Anna Hanchar, yes, please unmute yourself, Anna.
Thank you so much. I completely failed to understand how to raise a hand digitally, so here I am. What I want to say as kind of the last bit, which I completely forgot to mention in my presentation, was a huge thank you to all the people who participated in this study. It was completely invaluable to have everyone on board, and in the environment that we had to work in, I think that participation and that commitment and that incredible gift of time and creativity was just unbelievable. And I just wanted to specifically say thank you to volunteers of the group of paralegal counselors who helped us to collect the data as well. I don't know if there is anyone from that group here, but I think it was just a remarkable work that they've done, considering the environment and considering the limitations and boundaries of how we had to work. So thank you, everyone. This is exactly what makes things happen, especially now.
OECD yesterday had a round of government aftershock global events, which is online. And one of the comments that stuck in my mind was that we have enough of content. What we require now is connectivity, cement to cement these linkages and whatever content is there. And it seems to me that we are really, we have been working exactly in this spirit in the past couple of years. And I join Anna in thanking everybody involved, absolutely. Supporters, funders, those who are on board, and very much looking forward to the results of the RCT. Thank you. Thank you.
So we say goodbye to each other, right?
Unless you have nothing.
We will
Time
share
to say goodbye.
about the next round.
Say goodbye. Yeah.
Thank you. Thank you.
Thank you very much. Goodbye. Thanks.
Goodbye.
Thank you, Dagmar.
Thank you,
Anna.
Karla. Thank you, Khatuna.
Goodbye.
Thank you.
Bye, thank you.
Thank you very much.
Okay, maybe we can have 2 minutes with the team.
Sure, and I will stop recording.
Yes, please.
There's, I only have enough